as usual, in terms of CME, no disclosures financially in the past or in the present to report. There is some information on continuing education credits, which of course Rana will also send out. And the talk today is details of formulation and dosing of buprenorphine. The history of this talk is it wasn't really initially a part of our 12-week kind of rotating series that we do. One of our earlier participants who went through the course and is now actually a really sort of experienced buprenorphine prescriber, he was part of the study cohort, had requested that we do sort of this talk, going over some of the very basic details, of different formulations. So that's how this talk had come to be. And since then, of course, we'll try to update it, here and there as new information becomes relevant. So we're going to describe the differences between the different formulations of buprenorphine, discuss the difference between protocols of home-based induction and clinic-based induction, learn about some of the dosing and duration of maintenance treatment, and finally create a plan for managing the process of medical withdrawal from buprenorphine. Those are the things, and again, it's going to be a big overview. We actually go into a lot of the subsections of this talk and devote entire talks to them. So this is kind of more of an overview for people. So as we begin, note on formulations of buprenorphine. So this is just a list, and I know there's our Bear Valley contingent present, and this is a list. California Healthcare Foundation has made this available. It's public domain, and it's available in many forms, but I found the one that California Healthcare Foundation has made available the most user-friendly. So that's what I've included here for reference for you guys. There are many different forms of buprenorphine available. Of course, there's the IV buprenorphine, the Buprenex, which we don't use in treatment of opioid use disorder. That's actually used more for treatment of acute pain. Believe it or not, the first documented use of buprenorphine in the United States was the use of this IV buprenorphine to treat pain related to myocardial infarction, a heart attack, back in the 1960s. So that's actually the first indication for it. We also have a transdermal patch as well as a low-dose buccal film, which are both also indicated for chronic pain treatment. Then when we talk about treatment of opioid use disorders, right, then we've got the buccal film, the sublingual tablets, the sublingual films. There is also a buprenorphine implant, which actually recently got taken off of the market, very recently, not because there were any safety concerns, but because there was no market for it. People were just not opting to have a minor surgical procedure to have the implants inserted. So it's no longer on the market. There is also what's not listed here is the injection, the sublocade injection, as well as you can do compounded formulations of buprenorphine as well. So in terms of the basic principle of dosing, right, for those of you maybe considering starting out, as much as possible, we recommend using the buprenorphine naloxone combination, because you can find buprenorphine as a mono product without naloxone added to it, or you can find buprenorphine naloxone combination, right, which is available as tablets or strips. Again, the recommendation is that as much as possible, we should be using the combination medication. Why is that? Well, the reason is that naloxone that's added to it, if someone takes this prescribed sublingually or by oral injection, it doesn't really do much. It's not absorbed well, and it doesn't do much. However, if someone decides to misuse the prescribed medication by injecting it or even snorting it, that naloxone, which is a powerful opioid antagonist, will kick in and will cause withdrawal. And that's really why naloxone is added. It's included to decrease the injective misuse of the medication. So the only times when we use the buprenorphine mono product without the naloxone added to it is in pregnant women, and if someone has a documented allergy to naloxone, just to be safe, we avoid it. But otherwise, we use the combination. And there are three different formulations. There is the film as two different forms of tablets, all equally efficacious. Film or tablet, this is largely driven by third-party considerations. What's available in local pharmacies, what's covered by insurance. Here in New Mexico, I tell you that it's the film that's most widely available and most likely to be covered, certainly our Medicaid. There is some indication that film dissolves quicker, so it might be easier for the patient. That being said, I've had patients who just hate how the film feels and prefer the tablets. And films are also individually wrapped, so it'd be easier to track in terms of your diversion management plan. So in my practice, I tend to use the film for the most part, the combination films, but that's again largely because locally, that's what's most likely to be available. And again, there's the injectable and implant formulations now available. Implant is off the market. Currently, there is one injectable formulation called Sublocade, which is a subcutaneous injection given in the abdomen once every 4 weeks. Another new formulation of subcutaneous injectable buprenorphine is about to be released into the market. So that's going to expand our treatment choices. I think there are pros and cons to both, right? Self-administration is our traditionally used sublingual films or tablets. It is the current standard of care. It's available in many doses, many different formulations. It's widely acceptable. On the flip side, there is diversion risk, right? And the cost is moderate. When we talk about the injectable formulations, right, there isn't as much clinical experience. They're being used more and more. There isn't as much clinical experiences. The number of doses, vehicles, formulations is growing. Right now, we only have one in the market, but it's about to expand. They're not widely accessible. There's a closed distribution system. And to me, that poses a major barrier to treatment with injectable buprenorphine. So if I want to prescribe it to a patient, I actually have to go through a specialty pharmacy, get all the insurance approvals, get the medication shipped to my clinic, and then sort of administer it to the patient through one of our providers or nurses. So it's not very patient-centric. It's not very patient-friendly. On the other hand, compliance goes up because it's monitored injection once every 4 weeks, and it's also substantially more expensive. Without insurance, I believe one injection costs somewhere in the range of $1,700 to $1,800 per month. So it's quite a bit more expensive. So those are some pros and cons, and ultimately we make the choice based upon our patient interactions. When do we at our clinic use it the most? We have used it, for example, we have a handful of patients who are on the injectable buprenorphine. A few of them we are using because, for example, they were at risk. They were in a domestic violence type of a situation, and they were at risk of intimate partner violence if they had the medication, the buprenorphine, with them. So switching them over to injection really was a way to protect them. Similarly, I can think of a couple of patients we've had who lived with their parents, and the parents said, if you're on this medication, you can't stay with us. You'll be kicked out of the house, which of course we don't want. So we switch them over. Occasionally we have used it if we really, the risk of diversion has remained elevated despite being in place a diversion control plan. First thing. Second thing I want to go into is induction. When buprenorphine came out, induction again being a fancy word for the dose of buprenorphine, the process of getting someone onto the medication. When medication first came out, the recommendation was that induction of buprenorphine must be done under direct medical observation in a provider's office, but we moved away from it, right? A lot. The question is, of course, is a home induction. The patient starts the medicine, comfort of her own home, when she feels ready, when she's ready to start. Is it feasible? Is it safe? Is it effective? And I think the answer to all three of those questions, resounding yes. The data is pretty clear that home inductions and directly observed clinic inductions work about equally well in terms of safety and feasibility, right? Patient selection for home induction, I would say consider doing a clinic induction, right, in the following patients. Patients who have a low tolerance. Not sure the patients are going to tolerate the medication, right? Patients who have been living in a sober living facility or possibly been incarcerated. Patients who are transitioning from methadone. Methadone transition can be very difficult. And we're dealing with such a transition right now in a clinic, and it can be extremely challenging. So those patients I tend to do in doing under direct observation. Patients who have cognitive impairments or psychiatric comorbidity or suicidality. We want our patients to follow the instructions we provide. And, if because of cognitive reasons, that's going to be difficult to do, we should consider doing directly observed induction. Finally, we have some patients who have either no prior buprenorphine experience or significant fear of withdrawals. These are the patients who are like, I'm just so worried that when I take buprenorphine, I'm going to go into withdrawals. So we offer them the option. Well, if you wish, we can do the induction in the clinic just so someone is watching you and we're able to treat withdrawals if they do, to work with the patient to calm down their fears or anxiety. But for most patients, I would say home induction is really the preferred manner. I've included a few slides here for the process as reference. But in general, the idea is you still wait until you're feeling really lousy. You tell patients to wait at least 12 hours since the last use of short-acting opioids. And if they're using long-acting opioid medications, we have them wait at least 24 hours. And I tend to send them home with this scale. It's called the Subjective Opioid Withdrawal Scale, or the SOWS. It's a validated opioid withdrawal scale that's been designed for self-administration. So I send patients home with it, and I tell them, score yourself. And you want a target score of at least 17, which is sort of mild to moderate withdrawals before you start taking the buprenorphine. And then I essentially have them start with 4 milligram doses, repeating every couple of hours as needed until patients get to about 12 to 16 milligrams on day 1. And we check in with the patient on the phone on day 2, see how things went. And again, on day 2, they just continue the process. They do more 4 milligram increments until they feel better or until they get to 16 milligrams. So you can see that if we use that target dose of 16 for most patients when they're starting out, we can get patients there within the first couple of days. If you need it, then you can stretch it out to day 3. But in general, in a couple of days, we can carry out a home induction. These are just some magic numbers, so to speak, for reference. If someone's been using short-acting opioids, we tell them to wait at least 12 hours before starting the medicine. If they've been taking long-acting opioids, we tell them to wait at least 24 hours. If they've been taking methadone, then it's really advisable that they wait at least 36 or 48 hours. And again, I tend to recommend that they come into the clinic for an observed induction, right? And before starting, I talk about the possibility of precipitated withdrawals and our ability to treat it. Transitioning from methadone, again, I've talked about this. It's a challenging process. We first got to bring our patients down to at least 40 milligrams or less for minimum of 1 week. Then we go without methadone for at least 48 hours. So we can imagine how difficult this process would be for our patients. They're going through withdrawals. So we try to give them comfort medications to take the edge off. And then we start the process of induction. Precipitated withdrawal. Someone, of course, takes buprenorphine too soon after taking an opioid. The buprenorphine can throw them into opioid withdrawals. And that's what we call precipitated withdrawals. How do you manage it? So first of all, as I mentioned, I talk about this ahead of time with the patient. Get their buy-in. If this happens, stick with us. We know how to treat it. Second is a bit of good news that precipitated withdrawals are actually quite rare. If you look at the nationwide data that is available, you see buprenorphine precipitated withdrawals in under 5%, certainly of all induction. So vast majority of buprenorphine inductions can happen without this. And if you really kind of take a microscope and look at those 5% of inductions where precipitated withdrawals did happen, a vast majority of those tend to involve transitions from methadone. At the same time, increasingly, we're starting to see people who are switching from fentanyl and our illicitly manufactured fentanyl and synthetic fentanyl analogs also having more incidences of withdrawals. And that's something I'll touch upon in the next few slides. Now, the other thing that I've sort of added a couple of slides on, and I believe we're going to do a whole talk on microdose inductions in the next, I think in a couple of cycles, as sort of one of the rotating talks. This is something we're starting to do more and more. And nationwide, people are starting to do more and more. And the idea of a microdose buprenorphine induction is that we administer small buprenorphine doses in a stepwise manner to reduce the risk of precipitated withdrawals and pain. And this is especially useful in patients with chronic pain or those that are unable to stop using illicit opioids. Doesn't withdraw. Patients can, taking whatever opioids they're taking, start adding a little bit of buprenorphine at a time. The idea being that each dose of buprenorphine will kick out and displace a tiny amount of whatever opioid they're taking. So it's a very gradual cross titration process. Hopefully patients don't really feel it. And once patients are at a good dose of buprenorphine, after that, you can taper off whatever opioids they're on. There are different methods available. There's a method that uses the transdermal butrans patch. There is a method that uses sublingual buprenorphine, and people are also doing combinations of the two, right? So people do it different ways. This is classic slide, a design of the buprenorphine microdose induction method that utilizes small amounts of sublingual doses. So again, the idea is, say I go and see Dr. Jacobson, and I've been taking oxycodone, long-acting 15 milligrams twice a day. She keeps me on it. I keep taking it. I'm really worried that if it stopped, I'll have terrible pain. I'm not ready to do it. Dr. Jacobson says, sure, keep taking it. Then this is how she starts. And you can see on day one, I start with a low dose of 1/4 milligram of buprenorphine. Remember, in a standard induction, I might be starting with a 4 milligram dose. Here I start with a 1/4 milligram of dose. Then on day 2, I take a 1/4 milligram twice a day. Day 3, I go to 0.5 milligram twice a day. Day 4, 1 milligram twice a day. And meanwhile, I'm still taking my oxycodone long-acting, right? Then I go to 2 milligrams twice a day, 4 milligrams twice a day, and then 12 milligrams a day. And when that happens, that takes about a week. Then Dr. Jacobson might tell me to taper off of my long-acting opioid over the next 2 or 3 days. So it's a new thing that's being done increasingly. And I tend to use it in my patients with chronic pain or patients who are just not able to stop using whatever opioid it is that they're using long enough for the induction process to happen. So some thoughts now, maintenance dosing. So, in terms of dosing considerations, FDA has approved buprenorphine for up to 32 milligrams. That being said, most insurances will cover up to 24 milligrams. We used to say, if I presented this to you 2 years ago, which we did, I would say that most people don't need to go more than 16 milligrams of buprenorphine. But there is some new data coming out that shows that 24 milligrams of buprenorphine tends to lead to better treatment retention, which is something we want to see compared to 16 milligrams. Also, as more and more people are using our high potency synthetic opioids, such as fentanyl and carfentanil, it seems like these patients might need higher doses. So there's new data, new studies are also being designed to look at exactly this idea, that do we need to now use higher doses of buprenorphine? And early indications are that yes, certainly for someone who's primarily using fentanyl, you ideally do want to maximize buprenorphine to 24 milligrams and even 32 milligrams if needed. They may need higher doses. We don't have a whole lot of data, but it's coming. We have some data. Duration of prescription. This is a question that often comes up. In general, we try to tie how long a prescription we provide to how the patient is doing. So when the patient is doing well, they're in remission, they're complying with treatment, maybe they're meeting their functional goals, maybe they have a job, they're taking care of an elder, we try to give them a longer prescription or maybe even a refill. On the other hand, when patient is not doing well, when the patient is struggling, maybe needs more monitoring, then we provide shortened durations, right? Just to give them the extra support. And that's the conversation I have with my patients, that this is not punishment, this is not a reward. It's really just geared to meet you where you are and make sure that you're not slipping through the cracks. And I tell my patients that feel free to tell us. If I'm giving you a month and you feel like, well, doc, I'm really struggling right now, I'm under a lot of stress, I'm feeling weak in my sobriety, I need to see you more often, let us know and we can honor that, and vice versa. But in general, this is sort of what we tend to follow at our clinic. Once the induction is done, we might do weekly scripts at each visit for 4 cycles, then go to every 2-week scripts for 4 cycles, then monthly, and then maybe monthly with a refill for some of our more stable patients. Now, just a note on diversion management. We have an entire different talk on this as well that we've done. But these are standard things that we all should be doing. Urine drug screens should be done at each visit, including a point of care testing for buprenorphine. We, of course, should be monitoring the prescription monitoring profile. We should be talking about safe storage, providing lock boxes, educating our patients on it, and 48-hour callbacks. So at our clinic, all of our patients know, and they know this ahead of time, that once every few months, 4 months or so, 4 to 6 months, they might get a call from our clinic saying, hey, This is your random callback. We tell our patients, keep your phone number updated. And if you're going to be out of town, please let us know so we're not calling you at that time. Otherwise, they get this random callback. Once they get the callback, they have 48 hours to come into the clinic. When they come in, it's a quick process. They sit down with one of our medical assistants who counts the number of pills or strips to make sure the count is accurate. And that's when they provide a random observed UA, which is then sent out for kind of a confirmatory urine drug testing, including buprenorphine metabolites. Those are expensive. It's not convenient for the patient. So we don't want to be doing it all the time. But even just doing it 2-3 times a year can be a really good part of your diversion management plan. Now, regarding HPSOs. So the question is, what the heck is HPSOs? So HPSOs really stands for high potency synthetic opioids. And by that, we really mean illicitly manufactured fentanyl and its analogs, which are, as we may know, really rising around the United States, right? So there's some data starting to come out around fentanyl. So one is that role of buprenorphine. So it seems like buprenorphine treatment still works. There's at least this one study from last year that shows that treatment retention and abstinence rates appear equivalent, whether the patient was primarily using heroin or fentanyl. But again, some data has suggested that maybe we need slightly higher doses. Most people are doing fine with inductions, but there are increasing reports of more people experiencing these precipitated withdrawals if they were taking fentanyl or fentanyl analogs. And people have started looking into why this might be. So one reason is that fentanyl tends to build up in a body. It has reduced renal clearance. It's also lipophilic, which means that it's stored in tissue. And the more someone takes it, the more long acting it becomes, right? So those may be some of the reasons why we're seeing higher rates of precipitated withdrawals. So people are also starting to look at what works. How might we do an induction onto buprenorphine in someone who's taking fentanyl? And people have taken two different approaches. This is the microdose approach. So traditional buprenorphine induction, where you start with 4 milligram increments, should be avoided. One approach is this microdose approach, where you start by waiting longer. Some people are even waiting 24 to 48 hours after last use of fentanyl and waiting for an initial clinical opioid withdrawal scale of 13 to 15. In other words, moderate withdrawals before starting the medication, and then starting low, starting with no more than 1 or 2 milligram doses every 1 to 3 hours and trying to get to 8 milligrams BID by day 2. So small doses administered throughout the day and building up. And again, many likely need to build up to 24 milligrams, and some people who are using fentanyl may need that higher potency offered by methadone. This is a study that recently came out that basically found that compared to traditional modes of buprenorphine induction, when they started doing induction in slow doses of 2 milligrams at a time, administered every 2 to 3 hours, patients tended to fare better. They were more able to successfully get started onto buprenorphine. So again, start low and wait longer seems to be the way to go. On the other hand, Josh Lee out of New York, NYU, has taken the other approach, the macrodose approach. And he just published some of his early findings. And I do know from my correspondence that he's got a follow-up study that's going to be coming out. So he's taken the other approach. He's saying, well, let's just kind of get through the discomfort quickly. So he'll start people quickly. So, once someone is in mild withdrawals, give them 8 milligrams of buprenorphine. Follow it up by 16 milligrams. Essentially, the idea is to give a high enough dose to overcome that tolerance built up by fentanyl use. And after that, on as early as day 2 or 3, he will give them the injectable long-acting version of buprenorphine, because most of the injectable buprenorphine is released in the first few days at very high levels. So his idea is the exact opposite of macrodose. What's going to work better? We don't know. This is all early data, but I'm going to give a flavor for where the field is headed, some of the things that are being studied. Finally, withdrawal or tapering off of buprenorphine, right? There is no data to provide guidance on how long to treat a patient with buprenorphine maintenance. In general, here's the idea that when people are withdrawn, relapse rates are very high. And that's really what this data is showing. When we take away the buprenorphine, A vast majority of people, 80%, 90%, tend to drop out of treatment. And majority of them relapse, and overdose rates also go up. So really, we should be thinking about continuing ongoing maintenance treatment for as long as the patient is benefiting from treatment, right? And having that discussion with the patient. That's the idea, right? And keep in mind that risk of overdose is greater after withdrawal because of loss of tolerance. And those undergoing medical withdrawals should be warned about risks associated with loss of tolerance, and they certainly should be provided home naloxone. If withdrawal is done, if the patient insists on withdrawing despite having this discussion, of course we want to support the patient. And this is the approach I take. I work with my patient to set functional goals, and I tell them that we really should be keeping you on the medication until your goals are met, right? Until your life is stable, until your social networks are stable. You're not hanging around people who are using or who are going to lead to you using. And then do the withdrawal, do the taper gradually and at your own pace. You as the patient get to set the pace, not me as the provider. And the longer we can do it, the easier it's going to be. And even as we do the taper, I encourage patients to remain engaged in treatment therapy, 12-step programs. Once they're tapered off, consider switching them over to our antagonist treatment, the naltrexone depot injection, to provide a safety net while they build up their coping skills, while they build up their relapse prevention skills. And then you can simply withdraw the naltrexone treatment. So I will end here. It is exactly 12:30. So I'm going to stop here and see if anyone